Welcome to the Brown Surgery Podcast. Today we're going to kick off our Brown Surgery Quickshot podcast project. These discussions are meant to be only 10 minutes in length and focus on topics that we frequently encounter in clinical medicine and surgery. Today we're going to begin our critical care series with the Quickshot podcast on vasopressor selection in septic shock. It should be noted that source control should always be emphasized and questioned whenever you have a patient who either requires vasopressor support or who has persistent vasopressor requirement. With that, let's jump right in with our guest, Assistant Professor of Surgery and one of our critical care and trauma faculty here at Brown, Dr. Andrew Stephen. So I'd like to welcome Dr. Andrew Stephen to the podcast today.
Thanks for having me, Kenny. It's a pleasure to join the series.
Can you just run through some of the main classes of the vasopressors for us?
Absolutely. What we first think about is the adrenergic agents, which is going to include norepinephrine and epinephrine, as well as phenylephrine. But the key really is to understand your receptor charts from pharmacology. But you really want to know which pressors act on which receptors. So you want to think about alpha 1, alpha 2, beta 1, and beta 2. And so norepinephrine is probably the most important pressor. It has the most wide applicability for a wide range of processes, including septic shock. It can even be used for cardiogenic shock. That has gained some enthusiasm recently. So norepinephrine works on the beta 1 and the alpha 1 receptor mainly. And as the doses escalate, you get a little bit more of an alpha 1 effect from norepinephrine. But it's fairly balanced in terms of its applicability at those two receptors, beta 1 and alpha 1. And then epinephrine also works on beta 1 and alpha 1, but with slight preference to beta 1 compared to alpha 1. So you're more likely to get a tachycardia when you put a patient on epinephrine. Phenylephrine is a pure alpha 1 agent, so it really only causes vasoconstriction, and it provides no inotropy or chronotropy. Vasopressin as well, Kenny. So vasopressin works by a totally separate mechanism. That's a G protein second messenger system. And that doesn't really require a certain level of pH for it to be functional and provide effect.
It's also important when you're running through these vasopressors to consider some of the administration routes for them and how you're going to administer them to the patients. Do you want to mention anything about that?
Initially in the emergency room, it's pretty safe to give pressors through a peripheral IV. It's been done for a long time with dopamine, but dopamine's not really a preferred agent for us anymore for septic shock. And so you can give norepinephrine through a peripheral IV, but my preference is only to do that in the emergency room while you're getting set up to put in a central line. Usually these patients are sick enough where they require central access. So while there's literature, and there's an emerging body of literature over the last 5-10 years describing how pressors can be given safely peripherally, it's not my preference generally. These patients are usually pretty sick, and they're going to be on pressors for some period of time, so I would suggest getting central access on them.
So I think when you're volume resuscitating these folks and fluid alone isn't helping you to achieve your MAP goals, what vasopressor are you going to grab, Dr. Stephen?
Almost always I'm going to reach for norepinephrine first. And that's because of that balanced effect it has on the beta 1 and alpha 1 receptor. That blend makes it effective for disease processes like septic shock and even cardiogenic shock, or what is really common in the ICU, which is mixed shock, especially in our elderly patients.
Is there a certain titration strategy you're going to have?
Absolutely. So the first thing you have to do is establish what your mean arterial pressure goal is going to be, which in most patients from surviving sepsis is usually going to be 65 millimeters. And there's a long history behind this, why this has been targeted. In certain patients, we can reduce that goal to 60 based on how their end organ perfusion seems to be, based on urine output and some other measures. But I'm usually going to aim for a MAP goal of 65, and that's going to guide the titration of pressors.
At what point should one think about adding a second vasopressor?
I think with norepinephrine, if you're escalating in doses and you have a patient in septic shock, you really want to think about adding vasopressin on the earlier side. This has evolved quite a bit since when I was a resident, or even during my early years here at Rhode Island Hospital, where we would escalate norepinephrine to near maximal doses, and then we'd feel like it was a defeat to add a second agent like vasopressin. Now when I get to about mid-range levels of norepinephrine, let's say 10 to 15 micrograms, then I'll add a second agent. I want there to be a second mechanism at work, and there's also some benefits, it appears, that have come about from literature in the last 5 or 6 years, including the VANISH trial, which suggests with patients with septic shock that there may be benefit to earlier use of vasopressin in terms of glomerular filtration rate and overall renal function with improved urine outputs and creatinines in patients who were started a little earlier on vasopressin as that second agent.
That's a great point, and we can link that article to this podcast. I think another important pressor to consider when you should think about adding epinephrine to the algorithm, because as you know, Surviving Sepsis made a bit of a change in the last iteration, saying you could either add the second pressor, such as vasopressin, like you just explained, or you can think about adding epi at this point. How do you feel, and what's your strategy for adding epinephrine?
Great question. Epinephrine's traditionally been thought of as something for cardiogenic forms of shock, but as you mentioned, it's incorporated within surviving sepsis. And so there, I think it has to be very patient-specific. And they talk about this actually on some of the blogs, especially on PulmCrit, and I found those entries pretty interesting. And they suggest really targeting the patients. So they talk about this concept, interestingly, of epinephrine, of using vasopressin and epinephrine for certain patients who may have a slightly lower heart rate. And so these are probably going to be slightly older patients in general. Patients who do not have a classic compensatory response, or who probably have mixed shock with some form of septic shock as well as some myocardial suppression from the sepsis.
I think that's a good point. Obviously, I think with the evolution of bedside ultrasound being readily available, diagnosing someone with a cardiogenic component in shock has sort of taken center stage over the last decade, and I think epinephrine is really useful in this population of patients.
Absolutely. We thought of for too long that septic shock is a purely hyperdynamic situation, but it's very mixed, and it can be very patient-specific. And a lot of patients suffer myocardial suppression and are really hypodynamic.
I think one thing I want to mention briefly here is because I think we see it a lot, patients coming up from the operating room or perhaps coming from the ED, especially those with the diagnosis of sepsis or septic shock, and someone has hung phenylephrine on these patients. Can you just speak to that practice or talk a little bit more about who we really should just be reserving phenylephrine or neosynephrine for?
So yeah, phenylephrine, because it's purely with that alpha-1 effect, it's not really going to be our first-line agent for septic shock, or really any of the other forms of shock we have in the ICU. I'm usually going to transition off phenylephrine. It's okay if it was used for some post-anesthetic effect as a patient's transitioning from the operating room or the PACU to the ICU, but I usually want to then shift them to norepinephrine in that situation, because of that pure alpha-1 effect of phenylephrine. So what doesn't make sense to me about phenylephrine for septic shock or just about any other form of shock is how it's going to improve your end organ perfusion. You're not really going to get any forward flow from it. And so I do not like just that pure alpha-1 effect. Its main role is for patients in epidurals who have purely an issue with vascular tone, especially peripherally. So then I don't mind alpha-1 in that situation. Or potentially for mean arterial pressure augmentation with spinal cord injury. And even then, again, I'm not sure it totally makes sense for those patients when you think about the microvascular circulation. Does it really improve perfusion of the cord or perfusion of the microcirculation?
Great. So I think just some take-home points you'd like residents to get out of this quickshot podcast in terms of vasopressor administration.
So one of the first things, and I think Dr. Connolly is going to cover this in one of his podcasts, is really consider a fluid challenge initially if you're just receiving a patient, because you really don't want pressors unopposed in a patient without adequate volume status intravascularly. So it's always reasonable to start with 500 milliliters or a liter of fluid and then titrate some pressors on at that point. The second thing is you really need to understand the pharmacology and the receptor charts of each of the agents, especially the adrenergic pressors, alpha-1, beta-1, etc. And that vasopressin works by a slightly different mechanism that can be advantageous in patients that are acidemic, or when you want to add that second agent to potentially improve glomerular filtration rate and renal function. And so Kenny's going to give you a link to the Vanish trial, which I think is productive to look at, because we're adding vasopressin, I think, earlier than we used to, which is productive. And then understand the basics of physiology, and that you really need to have a target map, and your map is going to be the product of your cardiac output and your systemic vascular resistance. So when you take that into account, an agent like norepinephrine is going to have some effect on your cardiac output and some effect on your SVR, which is probably the productive way to use pressors, as opposed to phenylephrine, which is just going to affect your SVR and not improve your cardiac output and your so-called forward flow to an organ system or tissue bed.
Great. I think it's also poignant to note that being on pressors is not necessarily a bad thing, and I think there's this connotation that we've got to continue aggressive resuscitation because my patient remains on a vasopressor, and I don't think that's the approach we want our residents to take, because I think then you can get into over-resuscitation and dealing with untoward effects like compartment syndrome at that point. So I don't know if you want to just briefly speak on that.
Absolutely. I feel pretty strongly about that. When I was a resident, we really tried to wean pressors off. It was considered a sign of success of the resuscitation. And now I think we understand the disease processes a bit better. So when a patient, for example, comes up with perforated diverticulitis and they just got out of the OR and they had stool throughout their belly, to me it doesn't make sense to do everything to wean the pressors off. You might have to give that patient 10 to 20 liters to get them off pressors, which is a terrible way to take care of a patient, I think, especially in this modern era. So that patient should be on some norepinephrine, and they probably need to be on it for 24, maybe up to 36 hours while you resuscitate them. That patient obviously needs fluid too, but it shouldn't be let's wean pressors off at all costs.
Well, I think this is a great quick overview that residents should find helpful. So thank you for taking the time with us today and running through this.
A real pleasure, Kenny. Thanks for having me.
Thank you. Thanks again to Dr. Andrew Stephen for joining us today for this Quickshot podcast on vasopressor selection. I added the links for the VANISH trial and Surviving Sepsis campaign to the comment section below. Join us next week as we dive into a mechanical ventilation Quickshot podcast with Dr. Tarek Kierbeck. I would love to hear your comments on these and other podcasts that we have put together. If you have ideas for other discussions, please email me. The link to my address is in the comments section below. Thanks for being here, and I'm looking forward to having you back with us in the next episode.